That's going to start to come into play in 2012 and 2013. So by 2014, these exchanges will be up and running. There'll be one in every state. There is a requirement that there be health insurance plans sold in every state that are multi-state plans, so that there's many, many, many more choices for people. These exchanges will kind of be like many of the travel services, perhaps, that some of us use online, where you go online and you type in what you want to do, and then you'll see a menu of choices. Well, you'll have that now for health insurance, and you'd be able to choose which plans you wanted to use. There will be this individual mandate, and penalties will start to kick in 2014. It's important to have the mandate for a variety of reasons, and we can go more into this in the questions if you're interested. But really, for insurance to work properly, everybody has to be in. And under a scenario where a person cannot be denied insurance because of pre-existing conditions, the right economic strategy, probably for any of us, would be to wait till we got sick. And then if we get sick, then buy the insurance, because there wouldn't be any penalty in waiting. And so our insurance plans would end up full of sick people without any healthy people to sort of balance them out. And so that's the idea behind making sure that everyone is in and accepting their own little piece of responsibility to make this whole system work. So just to give you a sense of the penalties, because there's been a lot of questions about that, in 2014, the penalty would be the greater of $95 or 1% of your taxable income. And then that will slowly ramp up so that in 2016, the penalty would be the greater of $695 or 2.5% of your taxable income. So that just sort of gives you a sense. And then after that, it's going to be tied to cost of living increases. So there's a number of other provisions that will improve health information technology. There's tremendous support for a number of things like adoption services, giving moms better ability to breastfeed at work, research for trauma centers. I mean, all sorts of little provisions that actually, I think from my perspective as a physician, will make a really big difference in people's lives. So I think I'm going to end there. We'd be happy to take questions about where the money's coming from and all that sort of thing when we get to the question and answer part. And I'm going to turn it back over. Thank you.
Today at the City Club of Cleveland, we are listening to a Friday forum featuring Dr. Valerie Arkoosh, President of the National Physicians Alliance. We will return to our speaker in a moment for our traditional City Club questions. We encourage you to formulate your questions for our speaker now and remind you to keep them brief and to the point. We welcome you to this City Club Forum. For those listening to today's forum through one of our broadcast partners, we want to remind you that all are welcome here at the City Club in downtown Cleveland. Please visit our website, cityclub.org, to see a full schedule of our upcoming programs. Our greetings go to those present in this room, especially to those who are guests. We hope you will join us in our ongoing civic dialogue here at the City Club. Now, we would like to return to our speaker for our traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphones today, our City Club Special Projects Coordinator, Lauren Sable, and Membership and Outreach Manager, Deborah Agasti. So first question, please.
My question has to do with these exchanges. Just what are they? Are they going to be a state agency or a for-profit corporation, or who's going to employ? Who will actually do the work?
The exchanges will be state-based, so each state will create their own exchange, and in fact a state could create more than one exchange if they wanted to. There's a mechanism for that. There's actually also a mechanism where a state could opt out of having an exchange as long as they assured that all of their citizens actually were able to get coverage in a way that was as cost-effective as the exchange. So there's actually quite a bit of flexibility. They will be nonprofit. They will be brought into existence by a set of regulations that are going to be written by Health and Human Services. So they don't actually, those regulations don't exist yet, so I can't really tell you every single detail of it. But there will be federal oversight, but they will be run at the state level, probably by state government or the state insurance regulatory body or some offshoot of that.
Thank you for that excellent overview. I wonder if you could say a few words about some of the implementation challenges, particularly from the point of view of states like Ohio that lie ahead now?
Sure. Well, as you heard, there's a lot of issues here, and that the way this bill is constructed is that everything is going to be done really state by state. So this is very much going to be a state-level implementation rather than any sort of national implementation. Although there will be sort of overlays of regulation, it'll be up to each state to make all of these things happen. So, for instance, one is these exchanges will have to be set up every place around the country. There is going to be a very important function of monitoring private health insurance companies state by state to make sure that they are actually following all of these new restrictions that I enumerated for you, and that they really aren't denying people with pre-existing conditions, or they really are writing policies to people for those things, that they're not dropping people once they get sick, etc. So there will be a lot of very important work done by state advocacy groups, watchdog groups, really state by state by state, to make sure that all of these provisions are put into place in the way that the bill intended.
Thank you very much for coming. You spent the majority of your time, of the 30 minutes, commenting on the expenditures, where this money is going to be spent. Would you spend a few minutes on where we're getting the money from? And also comment on the penalties that will be inflicted on an individual who doesn't buy insurance, and even on somebody making $100,000, whether that still isn't less than they'd have to spend on insurance over the years, and whether that same individual will in fact not take the penalty, spend it, knowing that he can collect on insurance when he gets sick.
So let me do the second part first. So your point is that, let me make sure I understand the question, that the penalties aren't high enough. Yeah, is that what you're saying? That has been the subject of a lot of discussion. And I think that that may possibly be the case, that the penalties aren't high enough, at least for somebody with significant personal wealth who could maybe pay out of pocket if they became ill, for instance. They might just choose to take the penalty and not buy the insurance. What we don't know yet is what insurance is really going to cost. Once this exchange is up and running and there really is some competition injected into the insurance market, which tends to be highly concentrated around this country, at least in major cities, how much, I don't know that premiums are going to really necessarily come down, but I think the rate of rise of costs, this sort of 30% increases that we've been seeing around the country, should pretty quickly come to an end. But we don't know exactly how that's all going to pan out. And so I think that that will be something that will be constantly re-examined over time to see if those numbers are sufficient and if it's working as it's supposed to. I think, though, my sense, and I've been all over the country in the last year talking about this, there aren't very many people who don't have health insurance right now that don't actually want it. I agree that there may be some, people out there with significant wealth, and they might choose to say, well, I'll just pay for this out of pocket if I get sick. But I think for the vast majority of Americans, they are desperate to have health insurance because they couldn't possibly cover the cost of any sort of serious illness. So I think that at the end of the day, most people are going to take it up. But we'll see. They may not. In terms of revenue sources, there are a number of them, which is why I couldn't get into it in the first 30 minutes. So things that are going to start relatively quickly. Well, the first thing that's going to start is that 10% tax on tanning salons. Just want to get that out. That would be the first thing to start. And then in 2013, there will be an additional 0.9% Medicare payroll tax on wages for individuals who make more than $200,000 a year and families who make more than $250,000 a year. The other thing that will happen in 2013 is that there will be a 3.8% tax on unearned income, interest, dividends, that sort of thing, also on wealthier taxpayers or higher income earners.